SHLI Health Leadership Institute, a center at the Morehouse School of Medicine, develops programs in the community to bring attention to health disparities that negatively impact the health, well-being, and life expectancy of its citizens. On this episode of SHLI Health Leadership Institute Presents, we present part 2 of our series on integrated care. The focus of integrated health is to reduce the stigma associated with mental disorders and illnesses, to improve access to mental health services by progressively integrating mental health and primary care, and to advance community mental health programs by enhancing resiliency and preventing mental illness.
Hello and welcome to SHLI Health Leadership Institute Presents. SHLI Health Leadership Institute is located at Morehouse School of Medicine. I am Dr. Martha Okafor, and today joining us are representatives from two community service boards. These are health centers that are contracted by state of Georgia to provide mental health, substance use, and developmental disability services in the state of Georgia. And we will be talking about their collaborative efforts and exceptional leadership in integrating mental health, substance use, and primary health care in their settings. Their goal being to improve the health outcomes of their patients, as well as to reduce the associated stigma that is related to mental health. So joining me today are Linda Martin of McIntosh Trail Community Service Board, Debbie Strauss of Cobb Community Service Board, and Pam McCullen of McIntosh Trail Community Service Board. We will be talking about their initiative and their partnership with SHLI Health Leadership Institute as part of the collaborative community of practice. Thank you so much for being here.
Thank you for having us.
Thank you for inviting us.
So I'll start because I know that you have done a lot of work and led the way in terms of integrating mental health, substance use, and primary care in different ways and different partnership. However, you joined SHLI Health Leadership Institute and got involved with us about 3 years ago. So I would like to ask Pam if you could start to tell us, how did you get involved with SHLI Health Leadership Institute Integrated Care Initiative?
Okay, thank you. Our agency has been interested in integrated health for past 5 to 6 years, and we have really looked at and explored how we could provide this service. We have been a partner with Kaiser Permanente Foundation, and I received a letter from Ms. Yvonne Yancey telling me about the curriculum development through the SHLI Health Leadership Institute. At that time, it was kind of an open meeting, and if you were interested, you could call. So I remember calling and saying, could we come and participate and talk about this, because we were very excited about the opportunity to participate in a learning curriculum that could be utilized by our staff and by our partners. So I attended the first meeting that was held at Morehouse and was very excited about this opportunity of looking at the different areas of practice change and leadership and sustainability, and how do we go about working to make that happen, because it's such an exciting field of integrating primary care and behavioral health.
Oh, thank you. And Debbie, what about how did you get involved with SHLI Health Leadership Institute initiative?
Well, thank you again for having me here today. Like Pam mentioned, our agency has been involved for several years in integration of behavioral health and primary care. We too have started with a Kaiser initiative, as well as a separate research project with Dr. Ben Druss and Emory University. At the time that you sent out the letter, we had just begun our SAMHSA grant, which is a major grant that we're in year 4 now, to integrate primary care and behavioral health in the behavioral health setting, creating a healthcare home. Myself and Mr. Todd Citron, who's our executive director, joined in the first meeting and felt that this was a great opportunity for us to learn from others. Again, we focused on the development of the curriculum in that first collaborative, where we looked at leadership, practice change, and sustainability. 3 key areas for someone who's beginning to do integration.
Thank you so much. And I know, Linda, you joined us later on. How did you join the collaborative?
We had, again, the grant from Kaiser, and originally we're looking at bidirectional, and as we moved more to putting a behavioral health consultant in the primary care, Pam suggested I start coming to the meetings as well so I can learn the ins and outs and the challenges and successes of others.
Well, thank you. I know that your clinics are basically serving patients or people that have mental health challenges as well as maybe substance use. There will be comorbidity. And some of them have developmental challenge or cognitive challenges. And then you are working in different approaches to really integrate and address their medical health care needs. And it would be interesting for our viewers to know why this is so important, because we know that the evidence shows that persons that have mental health needs as well as other medical chronic health conditions, especially those that have severe and persistent mental illness, that they die 25 years earlier than other persons that have just chronic medical health conditions, and largely due to their unaddressed medical health problems. So your integration of all these, the head and the body, is actually very critical. I mean, the head and the mind, as part of the body of your patients, are very critical action that you're taking. So, and as a member of the community of practice associated with SHLI Health Leadership Institute, what does the community of practice mean to you? What role did you play? How did being a member of this practice help you in any way with effective work you're doing?
Well, that's a lot, Dr. Okafor. You're so right about the people with mental illness dying on average 25 years sooner. And that was one of the first things that Linda, our pharmacist, talked to me about when I joined the agency about 7 years ago. And I was just very intrigued by this, concept, and how have we missed this for so long? And so as I began to learn more about it and learn about the medical conditions affecting the individuals that we served, it became critical to our going forward that we needed to learn more about this integration and how can we help those that we serve to improve their health outcomes. So when we had the opportunity to participate with the SHLI Health Leadership Institute as a way of looking at the practice change and the changing of our culture, I was very excited about that opportunity. Some of the things I've enjoyed is the learnings that you have provided, the leadership Dr. Satcher has provided to us, and then the opportunity to network with partners like Debbie through Cobb Douglas Community Service Board and other partners, and learn about what successes they've had, what challenges, and what are some of the things that they have done to improve the health of the folks that they serve. And that's, I think, all of our goals. So it's really important as we partner with people that we identify common goals and learn from each other. And we just appreciate the opportunity to share in that partnership.
Thank you so much, Pam. And Debbie?
Well, as I look at what integration has meant to us, first of all, we firmly believe in the recovery model. For all of our clients, and I believe the recovery model affects each and every one of us. And that translates to a holistic approach, tying the mind and the body, and being self-directed or person-centered, so that we take the empowerment, we get empowered to direct what we're doing for ourselves. In keeping with the recovery model, you can't separate the physical conditions from a mental condition or illness. So the foundation was there to really work toward a goal of providing holistic care. Another belief that I'd like to share is that this is about system of care changes. As we do integration, we are working to change the system, not just within our own agencies, but within our communities and even larger within the country, so that a community of practice provides an outstanding environment to work on system changes, because we do have the ability, as Pam mentioned, to learn and share, to find out what works, what's positive, what are the barriers, what are the challenges, and how do people overcome them. So it seemed like the natural approach to be working on these changes.
Well, thank you for sharing that. And then Linda?
Well, mainly the good thing is that this whole idea of integrated care really is new. I mean, this is not something that when we were all in school they taught us. This is something that we have to learn and figure out on our own, and going to a forum of peers that's doing it helps show you what works, what doesn't work, and how other people ideas to how to do it. I mean, what they do is completely different from what we do. We'd love to do the model that they set out, and there's other models of how to do the health home. So learning from each other is the main goal.
And I will ask then, could you share with us what you did, if I could piggyback on just what you said?
On what our program is?
Yes, what your program is.
What we are doing is we have a behavioral health consultant embedded into the primary care facility. So people come in and they're there to see their doctor, but as you come in, you know, with the primary care visit and with the headache or the back pain or they can't sleep, and a lot of those things, they have a mental health component. People with chronic illness, they need support with their behavior, you know, changing their behaviors to help support their healthy living. I mean, people with diabetes need to understand how to cope with that kind of diagnosis that's going to be with them the rest of their life, and learn how to change their behaviors. So a lot of the chronic medical diagnoses have a behavioral component, and what we want to do is be there to support the community and help everybody understand.
If I could add something, Dr. Okafor, to that, through the SHLI Health Leadership Institute, we received a mini grant to focus on those with congestive heart failure and depression. That we, through our research literature, we found that was something that we wanted to really look at.
Okay. And Pam, hold on there, and we will take a break right now. So stay tuned and join us as we return to a conversation on integrated care of primary care and behavioral health. Thank you.
More when we continue on SHLI Health Leadership Institute Presents. The mission of the SHLI Health Leadership Institute is to develop a diverse group of exceptional health leaders, advance and support comprehensive health system strategies, and actively promote policies and practices that will reduce and ultimately eliminate disparities in health. The SHLI Health Leadership Institute has 5 divisions that advance behavioral health, sexual health, health promotion and disease prevention, access to healthcare, and health policy initiatives. We develop leaders who can transform their families, communities, schools, work, and healthcare centers to improve health and well-being. We work with individuals, parents, students, schools, places of worship, doctors, communities, media, governments, and organizations to promote transformative leadership, good health, disease prevention, policies and practices that will ultimately eliminate disparities in health. Through partnerships and collaborations, we develop innovative solutions that are meaningful and help to reduce disparities that negatively impact health, well-being, and life expectancy. We seek and appreciate partnerships and treat our partners with respect and civility that results in useful, innovative programs. Our programs include, but are not limited to, leadership programs, postgraduate policy leadership fellowship programs, smart and secure children parent leadership programs, community health leadership programs, community programs, sexual health initiatives, re-entry and reduction of incarceration of Black male initiatives, integration of behavioral health and primary care, quality parenting program, childhood obesity, and community health initiative solutions to address health disparities and promote health equity across lifespans. visit our website at shli.msm.edu to see how you can partner with us to transform healthy communities.
We are back on SHLI Health Leadership Institute Presents. I am Dr. Martha Okafor. Before we went on break, we were talking about the integration of mental health, substance use, and primary care in a community mental health clinic, actually community service board that provide a comprehensive services to persons that are living with mental health challenges as well as substance use issues and developmental disability challenges. And at that point, Pam, you were sharing with the viewers about the initiative and projects that McIntosh Trail Community Service Board had implemented as part of the collaborative. Could you tell us more about that?
I wanted to kind of focus on one of the many grants we received from the SHLI Health Leadership Institute that help us to create a medical home or a health home for individuals with congestive heart failure who also had symptoms of depression. So we were able to screen those with partnerships with our local hospital and the primary care clinic to really focus on the health of those individuals. So we were able to identify mental health goals and physical goals, and then provide the kind of system of care or wraparound services that that individual may need to improve their overall health. And so that was very instrumental and an important learning for us as we partnered with our primary care partner to improve the health of people that we served.
Oh, thank you. And who is the primary care partner that you're partnered with?
Our primary care partner in Spalding County is the Hope Health Center. It's an indigent care clinic and serving those without insurance in Spalding County.
That's very good. Thank you for sharing that. Deborah, what about Cobb Community Service Board? What are the initiatives you implemented through the Community of Practice Initiative?
Our intervention through the Community of Practice is an extension or an add-on really to our current work through the SAMHSA grant, where we're creating the healthcare home. Our partner through that, our primary care, is West End Medical Center. This is a FQHC based in Atlanta. We wanted to step out of the box a little bit for our intervention in our SHLI grant, and we wanted to continue to build on the wellness component. We look at 4 components in the SAMHSA grant. It's called 4 Corners, and that has to do with behavioral health, substance abuse, primary care, and wellness. Wellness is a very important part of the integration. Obviously, it helps us all to be preventative and take responsibility for ourselves. So we wanted to do something a little bit different, and we looked at ways for stress reduction, anxiety reduction, and the impact that would have on one's blood pressure. What we did is we created what's called the relaxation room. And this room is very atypical for a behavioral health center. It looks like someone's living room. It's very soft lights. We have everything from sound therapy to music therapy to aromatherapy, art therapy, different ways that you can relax in an environment that might be very similar to one outside of the behavioral health setting. What we're doing is we have a clinician who is an expertise in mindfulness, and he is doing groups. So in the first year in working with our grant with SHLI, we ran 2 groups. They each met once a week. We had 3 cohorts, 3-month periods with 10 clients per group. And they very much worked on mindfulness, meditation, on imagery, to be able to physically have an impact on their blood pressure. And it's very exciting to know that the early data show that we indeed have lowered blood pressure in a significant amount. So we're very excited about that. Those groups are continuing. And in the second year, we added an area which is obviously of great concern for all of us, and that is reducing the number of smokers. So we're using the mindfulness to assist these clients who are trying to quit smoking, reduce their tobacco use, by again using mindfulness and related techniques. And we are just in the beginning of that, so it's difficult to report the data, but we're very excited as we move forward with a very sort of outside of the box approach to stress and relaxation.
Wow, that is very exciting. And it is very interesting that every center, comes up with very important intervention aimed at actually improving overall health outcome of your patient, both on the, medical health piece as well as the behavioral health. So you all are really setting a very strong exemplary experience and intervention out there. And going to Linda, who is the pharmacist in the panel, I know that you played a role in the aspect of your expertise as we look at the curriculum and how to train other clinicians on managing patients with comorbid condition. Could you tell us a little bit about your role?
They had developed a mobile application that would help support the physicians and providers in making clinical decisions based on somebody's diagnosis. It was actually really cool. You would put in your patient's name and demographics, and it would save your patient, and it would ask you questions for each visit based on the diagnosis that they had. Do they have this? Try this first. Second line therapy is this, and it really is a very supportive tool for the providers. And I think one thing, whenever you are combining two very different disciplines like this, there's a lot of, I'm not sure, I'm not an expert in that, I'm not sure what I need to do. And granted, we have our psychiatrists that are there for consultation. As we know, the primary care doctors are there for consultation, but it's always good to have something at your fingertips to support you, and that's one thing that mobile app is wonderful at.
If I could add something to that, Dr. Okafor, you were talking about reducing stigma earlier, and this has been very important because, as Linda was saying, many primary care physicians don't want to treat people with mental illness. And so this app gave them the confidence that they needed by having a tool that was readily available to them to try something. This is something that's been tested. It's got some research behind it. So this gave them more skills in a tool, again, that they could utilize in seeing the patients that may be seen at the primary care setting, which reduced duplication. The person doesn't have to go to two places to get their care seen. It's a one-stop shop more where they can get both their mental health needs as well as their physical health needs addressed.
And it takes the proven algorithms and makes them user-friendly. So they're not having to stop when they're in the middle of patient care to look up this or that. It makes it right there at their fingertips, which is, in the setting that we have, primary care doctors have, 5-10 minutes with somebody. Mm-hmm. They need decisions fast. They don't need to stop and then have to go look at something.
Well, thank you. And this algorithm, as you were mentioning, is part of the collaborative, the community of practice contribution and partnership with SHLI Leadership Institute that led to development of this algorithm as part of the curriculum, which will be made available to other clinicians that would like to really begin integration of behavioral health and primary care. So we really appreciate our partnership with all of you and the contributions you've made. I would like to ask if there are any challenges that you've encountered, because our viewers, it would be important for them to know at least one challenge that you've encountered or two, and how you were able to handle it or maybe not handle it, so they will know going into integrated care what to expect. Anybody can start.
I think in any change process, you can expect to have barriers and challenges. So I think we've shared, and that's been helpful in the community of practice as well as when we're at a national level, sharing with the other SAMHSA grantees. One area that's been a challenge for us, as well as everyone nationally, is that when you're integrating very different cultures and organizations, there's a change process. And it's very much like a marriage, and you have the courting period, and then the engagement and the marriage, and how do you resolve? And I think compromise is really the key things to look at. Mm-hmm. Respect and trust in the partners to understand that we may speak different languages. So one has to be willing to work through, no matter what partner they choose, whether it's a hospital, whether it's, another organization, an FQHC. Organizations have different cultures and modes of operation. The other one we've run into has been, we have primary care within our building as part of the behavioral health, but we still need to refer people to specialists, especially with these serious cardiometabolic conditions that we're seeing. And finding specialists that we can work with, especially for the uninsured, has been somewhat of a challenge.
One of our challenges, personal challenges for our project was really trying to explain to the clinicians exactly what our vision was and where we wanted to see this project move toward. And once we did that and got them to understand, and then we have a personnel change. And then you almost have to take a step back and do it all over again and help them understand where we're going, what we want to do, and how we're treating the people, trying to make these changes, which is different from what they've ever done. And so any kind of change like that, it kind of puts you back a little bit, and until this becomes more mainstream, it's a challenge.
Like Linda said earlier, this is not a practice that we learned in school, so mental health clinicians generally see people for 50 minutes or an hour, and so in a primary care setting, you're seeing people for 10 to 15 minutes. So you have to change your model of practice, and it takes a unique kind of a clinician, someone that's very flexible, that can adjust to change easily. And so that's been a language change, a practice change that we've had to work with our clinicians on. And then, as Linda mentioned, whenever you have a personnel change, then you have to, start all over. So that has been a unique challenge that we've experienced.
Well, this is great. Any last word or advice you want to give to our viewers?
I think that even based on what you shared, Linda, I think that it's important as people are beginning their efforts to involve the leadership of the organization. We were very fortunate. Our leadership was very supportive of integrated healthcare. But if you go on to develop champions in different areas, it will help to be able to educate staff throughout the organization. And that way, with the champions sort of spread out, if you have a personnel change, those champions can pass the word along, and you get a very strong support system upon which to build the integration practice.
Well, thank you so much, Debbie. And this brings us to the end of the show. Thank you for joining us, and see you next time.
Dr. David Satcher is director of the Satcher Health Leadership Institute. Dr. David Satcher is the 16th Surgeon General of the United States. Funding for this program was provided by a grant from the Southwest Hospital and Medical Complex